So I thought I'd create a video of a typical low back exam, just so you have an understanding of what you'll experience when you come into the office. So we first start off in a standing position, and I'll basically be checking some landmarks and seeing if things are in alignment. And then we're going to go through a range of motion examination standing. So the first thing I do is, Claudia, just stand there looking straight ahead for me. I'll check a couple of points on the skull to make sure that they're level, also that the shoulders are level, and then coming down to the pelvic region to see if there's any kind of unleveling. And I like to take a look at the feet and just see if there's any flat-footedness or what we call pronation, which is the Achilles tendon bending in, which is common with flat-footedness, because basically the structure of the spine starts at the feet. So we have to take a look at how all these issues may affect the lower back. And at that point, we go through a range of motion testing, and we'd stress various tissues, the muscles, ligaments, discs, and so forth. And so part of that would be doing the range of motion examination to not only look at flexibility, but also to see what brought out the pain. So Claudia, I'm going to have you bend forward like you're trying to touch your toes. Any pain with that? Right there on the left. Okay, come on back up. Any pain coming up? All right, let's try bending backwards. Does that give you any pain there? Okay. Then we're going to bend to the left side. Any pain with that? In that same spot? And let's go to the right. Any pain that way? Okay. Now, Claudia, I'm going to hold your pelvis, and I want you to twist to the left and see if that gives you the pain. A little bit on that spot, okay? And try the right. That's okay that way, and you've got better range of motion that way. So her range of motion is pretty good, but you could see that a couple of motions reproduced her pain. And I know that those motions stress what we call the lumbosacral ligament, and as well as some of the surrounding musculature. And she didn't have pain with some of the extension maneuvers, which would point more to what we call a facet syndrome, which is essentially a joint syndrome. So the next part of the exam is the seated portion of the examination. And again, we're trying to correlate and see what reproduces the pain. And typically, while the patient's sitting there also, I'm just kind of looking at what their posture's like, how they're sitting, and so forth. Same thing when a patient was standing, I'd be checking for posture both from behind and from the side. So the next part of this exam, Claudia, the first thing I'm going to have you do is just straighten your left leg. Okay, let me know if any of this brings out pain. And right side and down. No pain with either one. Now I want you to kind of slouch and drop your head down. Yep, and just stay with your head down a little bit. And then straighten the left leg in that position, and down, and right, and down as well. Okay, and just relax there. We'll be checking some reflexes. Yeah, that one really jumped, didn't it? And then we can also check for sensitivity, one side versus the other. And this we would do particularly if we were concerned about any kind of nerve root impingement, sciatica, that type of thing. So we check what are called certain dermatomes and see if the feeling is the same on both sides. We can use a pinwheel, which is another little instrument that we use that gives you a little more prickly sensation. But what we're trying to see is in the various nerve roots that come from the spine, whether that sensation that the patient feels is normal and equal on both sides. So Claudia, now I'm going to go to the lying down position. Okay. And I'm going to be moving your legs in various positions, and I want you to let me know if you feel the pain at all. And you can tell me if it's in the same area that you felt the pain before when we did all those tests, or whether it feels different. And so just interrupt me if you feel the pain. So we'd start with what's called a straight leg raise. We'd raise the leg to see if it reproduced any of the pain. And we're also taking a look at the flexibility of the hamstrings and low back for that matter. Bend the knee, and we're going to come up and again see if any of this is reproducing pain. It's been good. We check for rotation of the hips, and we're going to check kind of flexibility of the gluteal musculature, and then some internal hip rotation. Sometimes you have some involvement of the hip joint itself, and that rotation can kind of give you a good understanding as to whether you might be running into a hip joint issue such as arthritis. And then we would come, same thing on this side, not only checking flexibility but whether there's pain, and bend this knee. And let's turn. And we can see that she's tighter, doesn't have as much rotation this way, and that can be important. And then coming up, like we did on the other side, she definitely has restricted motion on those two compared to the opposite side. And that's an important thing that we want to see here is there imbalance, whether it's side to side or front to back. And now in this test, if she did have some pain in the back, we'd want to know if that pain was radiating into the leg. Some people come in with back pain and leg pain, which is called sciatica. So we want to see if that sciatic pain is reproduced as well. And then we can do things like doing dorsiflexion of the foot to see if we can put more tension on that sciatic nerve and maybe bring out the symptoms more. We don't want to provoke the symptoms too much, but that helps us with the diagnosis. And then we can do both legs together, and again to see flexibility and to see if it reproduces pain. And then I'm going to have Claudia hold it up and lower steadily and see if there's any pain when you're coming down. So we're checking for back pain with that and seeing once she engages some of those extensor muscles, is she able to control how fast her legs are coming down and how evenly she's doing it in terms of the motion. Gives us an idea of core strength, and it also tells us whether she's able to tighten that core and that back musculature without pain. It also kind of gives us an understanding too whether there may be some stress on the ligaments when she doesn't have the strength in the back muscles. Is that reproducing the pain? And then also from this we can check for some strengths. Again, if a patient has symptoms of sciatica, we're going to want to see not only how the sensation in the legs or the feet are, but also what are the strengths for those various nerve roots. So Claudia, I'm going to have you point your feet up toward your nose. There you go. Hold it there. Don't let me pull it down. Good. And that's called the L4 nerve root. Now we're going to keep the big toes up real hard. Good. That's L5. And now I'm going to have you scrunch your toes like that. And then we test real hard. Real hard. And she seems to have a little weakness on that left side again. So this is giving me both a neurological perspective on the pain as well as a musculoskeletal and mechanical problem. So Claudia, next step with this is if I can have you go onto your stomach. Now, one thing that I was talking about during the consultation is we want to have an idea of, number one, is the pain mechanical? So, you know, there are times that people have back pain and it's not anything with their musculoskeletal system. A perfect example of kidney problems, or kidney stones, urinary tract infections and things like that. That can cause low back pain. So the way we distinguish that is not only whether they have any symptoms of urinary tract infection, but also can we reproduce pain mechanically? Because if the pain is not a problem that's mechanical, we shouldn't be able to reproduce it. So that's one of the things that helps us confirm whether we have a mechanical issue, which is something I treat, or whether we send the patient to their physician because it's something that I cannot treat. So assuming that it's a mechanical problem, we're looking for the 5 basic tissues that can be pain originators: muscles, ligaments, joints, discs, and nerves. So again, we're trying to get an indication of maybe what's coming. And from the consultation, I already have some thoughts in my mind as to whether the pain is coming more from a muscle or a joint, just in how a patient tells me that the pain is best reproduced, you know, whether it's sitting or standing or running or when they're lying in bed. So these are all correlated as I do this. So the next thing is, again, we're going to be checking flexibility, in this case the quadriceps. Patient should be able to get their heel to their buttock. Then we're going to do the rotation. And we can see on this left side again, she just doesn't have that ability to rotate, which we could see when she was lying on her back. And then we want to do some extension. Just relax, Claudia. And here we're checking not only flexibility of the hip flexors, but again, we're putting some extension pressure on her back. And extension pain is usually an indication of joint-related pain or problems such as reduced nerve spaces that could be pinching the nerve. That's going to be accentuated more with an extension maneuver. And we do the same thing on the opposite side. Flexibility is good. You can see she's got easier flexibility again on that side, on rotation. And then we check the hip flexors. And it's not bad. And at the same time, we're extending her lower back, her lower lumbar spine, and see if we can reproduce the pain. And then we can even go a step further, both legs, and putting both to her buttock. That also hyperextends the spine. And then, Claudia, if you can put your hands behind your head. Behind your head?
My head?
Your other head, yep. Put your hands behind your head, and then I want you to lift yourself off the table. And then back down. And then you can relax your arms again. And again, another hyperextension maneuver. That can give us some information up top as well. But again, we're trying to hyperextend this lower back. Another thing that we do here is we check for leg length. And just get a visual idea with the patient relaxed, whether they have one leg shorter than the other. And as you can see, she does a little bit of a left short leg. And that's something that we're going to correlate with her x-rays, because we'll do standing x-rays and actually be able to see the top of the leg bone. So if we see a visual leg length difference on the left-hand side, when we take the x-ray, we're going to want to see if those femoral heights, the top of the leg bones, are level or not. Nobody's perfect. We're not looking for perfection, but we want to see that a person's any imbalance is less than a quarter inch on leg length difference. So that is basically the examination in terms of mechanical movements, and then the rest is more of a palpatory examination where I'm going to be pressing various portions of the spine, various parts of the actual vertebra. I'll be putting pressure in certain areas to kind of force the vertebra in one direction or another to see, again, if we can provoke the pain, if we can bring out the pain going in one direction more than the other. And we'll also take a look at how the muscles feel. Are they in spasm? Are the muscles tight as a drum and protecting that painful area? Or are they fairly relaxed when she's relaxed? So I check that, and so I'll just give you a little demonstration where I can just check the tone here a little bit. We can go over the spine at the various levels and put pressure, and I'd be asking her in this circumstance whether any particular level reproduced her pain. You know, there's various what we call spring tests where we can see how the spine is actually responding to when I put pressure. We'd expect it to sort of give and spring back a little bit if it's got normal motion. And that's a critical thing. We're trying to see if the spine itself and the joints are moving like they should be. And that is pretty much the examination. So taking into account the consultation, where I'm already thinking that this person may have a facet joint problem, for example. So on the testing, I want to see, is that consistent with a facet syndrome? At that point, I'm going to want to get further tests depending on what I suspect. But in a typical problem that's not disc related, we'd be doing just normal x-rays, and we'd be taking a look at things like whether there's a leg length difference, how the pelvis is aligned, how the spine itself is aligned, and are there other sort of more structural issues going on? Are there degenerative discs in the area? Is there anything else beyond what we would expect to be normal going on in the spine? There are developmental issues, for example. So we would check that, and then if I really suspected something, then I may consider an MRI or some nerve-related testing, particularly if we're dealing, or I think we're dealing, with a disc issue and true nerve compression. So that's pretty much it for the exam, and if you have any questions, call the office.